Welcome, everyone, to today's session of our survivorship series, Patient-Reported Outcomes in Survivorship, led by Dr. McCleary. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the survivorship team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center, as well as the survivorship website. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the Q&A feature throughout the session. At the end of the session, your questions in the chat will be used to moderate the Q&A. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource center or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the session over to our panelists.
Thank you so much. I am delighted to be able to share with you all today on this topic, amplifying the patient voice for improvements in care as a part of the Survivorship and Blum lecture series. So I'm representing a large team of colleagues through the Patient-Reported Data Program. I'm an associate professor of medicine at Harvard Medical School, an affiliate faculty within the Division of Population Sciences, senior physician within the Gastrointestinal Cancer Center, medical director of our older adult GI malignancies program, and very pleased to be medical director of this program, Patient-Reported Data. Today, we wanted to share a bit about key initiatives across patient care, and we'll focus on two large efforts, but feel free to ask about anything and everything that may be relevant to how patients engage with us at DFCI and with their care teams to really improve their own care. So a little bit about the Patient-Reported Data Program. So this program, as I mentioned before, really represents a collaboration of many, many individuals across Dana-Farber and Mass General Brigham Hospital within our information technology division, analytics, our executive leadership, and our operational and care teams. But most importantly, this team really centers around our patients, and we are ever so grateful for our patients' collaboration through the Patient and Family Advisory Council, but also individual patients who have selected to partner with us in this work. So what is patient-reported data? So patient-reported data encompasses a diverse set of data relevant to patient health. It is reported directly by patients without interpretation by a clinician or anyone else. So we're not taking information that our patients share and reinterpreting it. We're actually sharing directly what our patients have shared with us. So at Dana-Farber, this information is reported through questionnaires, and it flows directly into the health record. So it provides a reliable, high-quality source of information available to truly center the patient voice at DFCI. This information may include symptoms, quality of life, functional status, history, but also values, screening information, all the facts that you think may be relevant to how one receives their care and how they are perceived within the health system. It turns out that patient concerns really do extend beyond what treatment, trials, or trajectory, otherwise known as survival, one may have after a cancer diagnosis. And often when I meet with patients, in addition to asking questions about those things, patients also wonder, well, can I work while I'm receiving this care? How will I even get to Dana-Farber? Can I afford this treatment? Where can I live and be safe during treatment? How can I access food to support me during care? And I'm also a care provider for other people. So how can I get extra help for myself at this time? All of these questions we know not only to be relevant, but essential to the successful treatment of cancer for our patients. And we've seen this in a lot of studies really supporting the value of this work. So our program, again, its mission is to amplify the patient voice to improve three key areas: equity and experience for our patients, efficiency and innovation for their care team, and also quality and value for the healthcare system. So the value of using patient-reported data, I've mentioned before, has been shown in several key studies. And what we have learned through these well-published and well-presented studies is that patient-reported data actually saves time during a patient visit. We're then able to really dive into what are priorities and key concerns for patients as early as possible during that limited time. It streamlines patient and provider communication. So it's clear between the patient and the care team what is important, what's the priority, what's most concerning for that patient and their family. We also know that when patients are able to systematically report on their experience of care, we are better able to target interventions to address those concerns. And by so doing, we're able to improve patient outcomes. And we found that this improves survival. All of these are really key outcomes that we want to make sure and ensure that are available to all of our patients who are receiving care for cancer, but particularly at Dana-Farber Cancer Institute. So to do this, one of our priorities is to make access to patient-reported data accessible to all DFCI patients. This is regardless of where you receive your care across the DFCI network of treatment sites, what your primary language is, and whether you have internet access or not. So patient-reported data is accessible at all DFCI locations, available in multiple languages, and accessible via the patient portal if you have access to internet at home or on iPads that are provided in clinic. Patient-reported data flows directly to the care team. So once a patient is assigned a questionnaire based on their care status, if they're new or already receiving care at DFCI, or the disease center in which they're being evaluated, that patient's response then goes to the provider or care team within whom they are being assessed. But that information is also pulled up in aggregate analysis, so we can look at patterns across a disease center or a disease type or a particular experience, and really then be able to target some of our interventions based directly on what patients have shared with us are priority concerns for them. And so that leads to benefit of population health management, really understanding what a group of patients who may share a similar experience or particular diagnosis may benefit from in terms of the work that we're doing to provide care here. It turns out that we have been doing this for a long time at Dana-Farber. In fact, since the 1980s, we invested in collection of patient-reported data via paper for research, but it was not a part of our routine clinical care. Many providers, however, found benefit from looking at these questionnaires as they were meeting with particularly new patients. And so in 2017, we formalized that effort when we transitioned to the electronic health record known as EPIC. And our questionnaires then were integrated within the electronic health record, not only as a part of the research data collection, but also more importantly, as a part of routine clinical care. And so currently I mentioned that this is available at all DFCI sites in 7 languages and allows us to really target our interventions based on this directly reported information from our patients. Patient-reported data allows us to share this information throughout care. We have core questionnaires that are highlighted in the peach color, the new patient intake questionnaire, oncology history, and then for our established patients, symptom management and universal distress screening are also added to that. We have several disease-specific questionnaires. So if you're evaluated within the breast oncology center or head and neck oncology center, you may also be asked to answer information that will provide or share information with your care team, more specifically based on the disease that you're diagnosed with. And then for supportive oncology, this is across many disease centers. Patients who are receiving care within our psychosocial or supportive care departments may also access questionnaires that are relevant to the care they receive. We are focused on improving outcomes for our patients. And so we spent some time really developing a robust infrastructure to support this effort, and then growing and expanding based on the needs expressed by our patients and by the Institute. And then innovating and enhancing upon that work, fine-tuning collaborations with different groups, and now very importantly, focus on improving outcomes based on what patients have shared with us. So today, just wanted to highlight a few key initiatives across patient care at Dana-Farber that is based on patient-reported data. The first applies to patients who are new to the institution who are scheduled for their first consultation with a medical, radiation, or surgical oncologist at Dana-Farber, and that includes the new patient intake questionnaire. For patients who elect to continue their care at Dana-Farber, The patient-reported data effort there is symptom management. And for those who have completed treatment or are being monitored after a course of treatment, ongoing symptom management around a particular adverse event. So a little bit more about the new patient intake questionnaire. Many who are part of this call or are watching online may have completed this questionnaire already. It turns out that most of our new patients are able to complete this questionnaire, upwards of 80% of patients across time. So we're very pleased that patients, even prior to their initial encounter with their oncologist, can share a bit about how they're feeling, or review of systems, their personal cancer history, their family's cancer history. They can tell us a bit about their mental or physical state prior to the visit, any vitamins or supplements that they're already taking. They can share a bit about their understanding of health information, so health literacy screening, and then tell us about any particular needs that they may have that are part of their lived environment, so health-related social needs screening. A bit more about health-related social needs. So health-related social needs are an individual's unmet adverse social conditions that contribute to poor health. These are social and economic needs that individuals experience that affect their ability to maintain their health and their well-being. And you can imagine, once diagnosed with cancer, these needs may be magnified. And they include employment, affordable and stable housing, healthy food, transportation, and utilities, among others. Since April of 2023, we have systematically asked patients coming into the Institute about health-related social needs. We have collected over 38,000 reports, so 79% response rate. And what we've learned is that at Dana-Farber, nearly 20%, 1 in 5 of our patients report a health-related social need. The top reported needs are food, utility costs, and housing security. But we also screen for an extensive list of other needs, including financial strain, family care, health numeracy, which is understanding medical statistics, which we throw out a lot in our conversations, and social support. So when you look at the hard numbers, that 20% translates into 2,000 patients in need of food security during their time at Dana-Farber. Nearly 2,000 with challenges addressing monthly bills, 1,600 with concerns around housing, 1,200 with concerns about medication costs, over 1,000 with concerns about transportation, et cetera. And these are responses reflecting data shared by our patients from April 2023 through November 2024. So you can see the need is great. And one caveat that I would add is this is what we know about patients at the outset of their first evaluation at Dana-Farber. But over time, we know that these needs may be magnified, particularly the deeper you go into cancer care treatment. And it's important for us to understand what the needs are at the outset that may be barriers to care, receiving care here, but also think strategically about ways that we can intervene. And so as a result of some of this early work, from May 2021 through July 2022, we conducted a study called Routine Evaluation of Social Determinants of Health in Oncology, User-Informed Resource Coordination and Engagement, or RESOURCE. And the best part about this study was that it was funded by patients for patients. So it was funded by Consano, which was a crowdsourced patient survivorship funding program to support research studies, and Team Bushy Strong, which is one of our fantastic DFCI walk teams led by Amy Ennis. We asked 416 patients to participate in this study, and they reported their health-related social needs, which generated an automated referral to our resource specialist office. And the resource specialist, in turn, would reach out to patients who expressed that they desired help with that need to address their concern. Now, prior to this study, what generally happened was patients would get to a level of distress, and then the resource specialist may be contacted, or the patient may initiate contact on their own. But there was not a systematic screening effort to assess and meet needs as early as possible during one's care. And so we learned through our resource specialty, and I would add our financial counseling teams that worked together on this effort, that they were able to more strategically address concerns that patients had and do so earlier in the course of their care. This effort then led to DFCI's investment and development of the CARES initiative, which is collecting and responding to social needs. This program aims to reduce the burden of health-related social needs experienced by patients who are new to our institute. Similar to the resource study, patients are asked at their initial visit by completing the new patient intake questionnaire to share any concerns regarding health-related social needs. If they express a need and they express that they have interest in receiving more information to address that need, that information is sent directly to the resource specialty and financial care teams, and they then in turn will reach out to the patient to assist with that need. Thus far, we've implemented this effort in 5 disease centers at our main campus to date, and will eventually implement across the institute, including our regional sites. Again, this started by a small effort funded by patients for patients that's now led to an institute investment in addressing these concerns. I'll then turn to another health-related social need, but give you a little bit more detail, which is health literacy. When we meet with our patients at the outset of our visit, we're sharing a lot of information, and oftentimes that comes at a point of some emotional or physical distress. Health literacy is simply the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and for others. You can tell already how vital this is to initial and ongoing conversations regarding a diagnosis of cancer and its management. Here, we implemented the Brief Health Literacy Screening Tool, which is a validated 4-item questionnaire that generates a health literacy score. The score designates health literacy as limited, marginal, or adequate. Limited indicates inability to read low literacy materials, repeat oral instructions such as symptom management instructions, and a need for simplified materials. Marginal indicates a need for assistance or a potential struggle with patient education, and adequate, able to read and comprehend the information that is shared. Prior to doing the study, we did not have a good sense of how challenging it may be for some patients to use information that's provided during a visit or provided between visits as needed for supportive care. And it turns out about 1/3 of the patients who have been evaluated thus far report either limited or marginal health literacy. This has far-reaching implications for how we approach patients at initial visits, but also how patients are able to utilize the resources provided throughout their care. Some of the impacts of low health literacy on patient care specifically include reporting poor health status at initial consult, having worse outcomes and worse experience of care, reporting more severe symptoms or adverse events during treatment, and also, interestingly, being more likely to stay at Dana-Farber for care. I think this information, one can surmise, may indicate that we have made substantial efforts at Dana-Farber to really assist our patients, but there's still more work to be done to assist those who have lower levels of understanding of the information shared, and maybe better strategies of how to provide that information. I'll then turn your attention to electronic symptom management, which really indicates how we assess and address symptoms or symptomatic adverse events that patients may experience throughout their care. So again, based on a large research study led by Mike Hassett and a large team of folks through the National Cancer Institute, we implemented systematic tracking and intervention for symptoms and symptomatic adverse events. This program, called Electronic Symptom Management, or eSIM, measures symptom severity, frequency, and interference in daily life, and generates a score around any of the listed symptom domains shown on the right. That includes no symptom, mild, moderate, or severe. We ask about 14 symptoms that we require across all diseases, and then there are additional symptoms that patients may elect to report on as well. The required symptoms really reflect core experiences that patients may have regardless of the treatment regimen or surgical intervention they may receive, which includes things like shortness of breath, constipation, nausea. And then optional symptoms include things that may be experienced intermittently, but a patient can elect to report on them if they're particularly distressing, such as painful urination, heartburn, or headache. Just go back. So symptom tracking and intervention with the eSIM tool, it's done electronically. So again, high rates of patients engaging in this effort, and it allows us to address historic gaps left by traditional symptom reporting, which depends on a patient calling or coming into clinic physically to report on a symptom. And oftentimes when patients do that, it may be too late. They've already experienced days, sometimes weeks of a symptom that could have been managed earlier. This reporting is provided for patients to directly report their symptoms with the impact of improving outcomes and improving communication with the care team. But also care teams can systematically review collected symptom reports, improve their workflow and timeliness to addressing these concerns, and provide more informed care decisions partnering with patients. And the healthcare system can use standardized data to hopefully reduce costs related to addressing these symptoms and develop population health management interventions. So these symptoms that patients are reporting fortunately represents most of our established patients. Again, the level of reporting has increased over time and now exceeds 80%. The number of patients reporting severe symptoms is about 15% of the population, and the most frequently reported severe symptoms include pain, overall well-being, and fatigue. So now with this information, we can better target interventions around particular symptoms or symptomatic adverse events. For some of these symptoms, we already have well-tailored and validated interventions that have been shown to be beneficial, and we wanted to start there where we already have a plausible solution. And one of them is around the symptom of insomnia. So again, this is a distribution of what patients have shared with us regarding symptoms or symptomatic adverse events experienced between November of 2022 and November of 2024. Fortunately, most patients experience little to no symptoms or symptomatic adverse events. Unfortunately, rates of moderate or severe symptoms still are fairly high when you look at the absolute numbers. And this issue of difficulty sleeping or insomnia really trends to be pretty high in terms of the numbers of patients who are experiencing it. And so we wanted to start by addressing that. We're fortunate to work with Dr. Eric Zhao, who's a part of the survivorship team and has developed an intervention to specifically address insomnia in a way that is easy and accessible for patients. So about 19% of patients report mild to severe insomnia based on the data I just shared with you. Once patients report that the first time, they are sent a link via the patient portal that includes a link to a video, and patients can review this information to understand ways in which insomnia can be addressed. While we know that this doesn't address everyone's concern around insomnia, it does address a substantial number and also provides a connection for more assistance to tailor a remedy for insomnia for patients receiving treatment here. And so in summary, I hope you from this presentation understand a bit about how patient data is being used to amplify patient voices at DFCI, but also ways in which it helps us to really target and develop focused interventions. So our focus is on tracking and measuring patient needs, measuring concerns, identifying trends, and then creating interventions that help to address them. What we've highlighted are new patient intake questionnaire interventions around health-related social needs and health literacy screening, and then symptom management efforts around measuring, tracking, and intervening on symptoms and symptomatic adverse events. But I want to highlight, as I did at the very beginning of the talk, that this is always a collaborative effort. In the midst of this are our patients, but around our patients, there's the support of large groups at DFCI, including quality and patient safety, which is the department in which we sit, but also nursing and patient care services, social work, financial services, our clinical operations, business analytics, information systems, cancer care equity, community benefits, pharmacy, and inclusion, diversity, and equity. So we're so grateful for the collaborative work of all of these teams to really enhance and improve care that patients receive here at Dana-Farber. Thank you so much for your time.
Thank you so much, Dr. McCleary, for that excellent presentation. As mentioned earlier, the session was recorded and it will be posted on our Blum YouTube playlist, our Blum Digital Resource Center, and the survivorship website. I haven't seen any questions come through, but again, to the audience, please let us know if you have any questions.
I just saw one.
Let me see. How can we donate to the patient-to-patient assistance?
So many are aware of the fantastic philanthropic efforts at Dana-Farber, some of which are large scale, but there's certainly many opportunities to volunteer either time, effort, or provide financial donations. So if you were to connect with the DFCI philanthropic office, either within your disease center, or if you simply go to the DFCI online website, you will be able to find connections to that office. So the Division of Philanthropy, and they would be happy to assist in how to contribute specifically. I will put in a plug, particularly during this season, the holiday season, is a lot of need. And so any and every contribution is more than welcome and definitely used to directly benefit patients. And we're also open to ideas. So if you are a patient or a family member, proxy for a patient, and there are things that you have observed or questions that you have, we'd be happy to engage with you as well.
Awesome. So it doesn't look like we have any other questions. So we will end it, but the recording of this will be posted. So please look out for that. Thank you again so much, Dr. McCleary and the whole survivorship team for coordinating and working with us.
Thanks so much, Dr. McCleary. We really appreciate
Thank
it.
you.
Thank you.
Thank you.
Thank you all. All right. Take care.
Bye-bye.
Bye.